Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Tiffany Claiborne, and I will be your webinar host for today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is the 6-minute wrist and hand exam, and our speaker is Dr. Cliff Gronseth. Dr. Cliff Gronseth is an accomplished physician, inventor, entrepreneur, and decorated ultrasound teacher. He recognizes ultrasound as a medical superpower and a key tool for any physical exam. Gronseth developed MSK Nav, a renowned ultrasound training platform, teaches ultrasound master courses worldwide, and is the founder of the nonprofit organization NYAGI Project, which harnesses the power of technology to teach prenatal and emergency ultrasound skills to local healthcare workers in the least fortunate regions. Let's welcome Dr. Gronseth.
Thank you very much, Tiffany. So I'm starting with this picture of a beautiful woman in Nepal and her baby. Just so you know, my daughter had a baby last night, so little sleep deprived, but we'll get through this with rapid speed because I'm well caffeinated. So today, I'm going to go over the wrist and hand. So it's a tall task to do in 45 minutes. We will get through this. My advice to you is just sit back, listen, absorb what you can. Hopefully this will be available for re-reviewing later because there's going to be a lot of information about what to do with approaching the wrist and hand ultrasound. Now, I'm going to start with a kind of an ocean, lake, pond approach, just so you understand where ultrasound fits into a clinical picture. Some of you already know this, but it's good to review. 75% of a diagnosis is just based on history and physical exam. The ultrasound is used for confirming what you think is going on and to look inside the body real time and see if it surprises you. So with that, that's why it's a superpower, because you can now look inside and help identify whether or not you're right or wrong. I've been using ultrasound for over 25 years. And before they had many courses, I used two books from Eastern Europe. That was the only thing that was published at the time. I've learned the hard way. I had a lot more hair when I started learning ultrasound, especially MSK ultrasound has been a journey. And just to preface it and give you a relevant perspective of MSK ultrasound, it's the hardest ultrasound you can probably do because emergency medicine ultrasound and abdominal, chest, OB tends to be larger body parts, except when you're looking at babies. And the MSK ultrasound is notorious for having the artifacts, especially the anisotropy. And we'll talk about that today. So you have the physical exam and the history, and then you've got basically three main modalities. You've got ultrasound, which is immediate and safe, as you know. You've got X-ray, which is really great for the bones. And then you've got MRI, which looks at the soft stuff and deeper into the body. So there are benefits and detriments to each one of those. The key thing about ultrasound, it is you can look at things moving, and especially with the wrist and hand, that dynamic evaluation is really what gives it that extra little kick for helping you figure out what's going on. So I have a couple of teaching points. I call it Dr. Cliff's tips and pearls that I'll give you throughout the lecture today. But starting from, again, the big picture, the focus for ultrasound, especially for a wrist ultrasound, because there's so many parts. I don't know if you realize, I counted this morning, there's about 30 bones. There's over 100 ligaments. There's probably 30 nerves, not just the main ones, but all the peripheral nerves, and the main arteries, and then you have the digital arteries. So there's hundreds, if not thousands, of things that you can look at for a wrist. When you're approaching a wrist ultrasound, you really want to have it focused on what you're looking at and what you're looking for. So you have You have a plan about what you're going to do. Just like if you were scuba diving, you plan your dive and you dive your plan. The idea is that the physical exam gets you so far. The ultrasound will allow you to confirm, like I said, confirm your diagnosis. And also you can limit what you're looking at. You don't have to look at every structure in the wrist if you're really focused on pain on the thumb side or the radial side of the wrist, or on the ulnar side, on the anterior, on the volar side, the dorsal side. So you can really tailor your approach. And that's the 6-minute ultrasound. There's no way you can do a 6-minute ultrasound, the entire wrist, the entire, and the hand and the fingers in 6 minutes. That's of any value. So you don't have to take a picture of everything, but you have to know what you're looking at and what you're looking for. With that, there's a couple of structures that you can use to plan your approach. I use a little saying called BLT, like the sandwich, bacon, lettuce, tomato, BLT, no ketchup. BLT, no bloody onions. Sorry, BLT, no bloody onions. And this stands for bones, ligaments, tendons, nerves, and then the bursa or the blood vessels, and then other. So, and that basically goes from deep to superficial when you're doing the scan, because once you start when you put the probe on the patient's body, you kind of get lost. You're like going back to this scuba diving analogy. You're underwater. You're looking at the sea cave with a slit lamp. Everything is dark, and you're trying to figure out where you are and what's going on. There's two different main buckets to do a wrist ultrasound. You have the acute injury, fall on an outstretched hand, a laceration, and then you've got the chronic conditions. This lecture is going to be focused mainly on the chronic conditions, simply because that's the one that is probably most useful for ultrasound in the average clinic. For an acute injury, X-rays are definitely a strong suggestion to get that first, because once you go into the ultrasound world, you may or may not see the subtleties of a bone spur or even a fracture, but you might see a little bit with the X-ray, which gives you a clue about what may be going on. Now, with that, you can oftentimes diagnose things that X-rays don't see. For example, an acute scaphoid fracture may not show up on X-ray because it takes a while for the waist of the scaphoid to disintegrate, but you might see some cortical irregularity or some swelling, periosteal swelling around the bone. So it's not an all or none, but just keep in mind that what you want to do is get as much information as you can so you make the right diagnosis, and then you can make the right plan. So let's get into it as best we can. So I'm going to do a screen share here, and I'm going to show my software. And so I created this software for learning ultrasound. I like I said, I did it the hard way out of anatomy books and ultrasound, kind of ultrasound guided books. So this was a software that I created. Let me actually turn this on just to make sure you can see it. So this is a software that I created with the help of some others to maximize the learning speed of ultrasound, because it's a very steep hill to climb. But I think if you chunk your information together piece by piece, you'll get more and more confident with what you're looking at and what you're looking for. So with that, I'm going to open up the wrist chapter here, and I'm going to run through the regions of the wrist. So you try to approach this scan just like you would approach shopping for a camping trip. You want to define what you're going to be looking for, what you need to get for food for your camping duration, and you might bundle it into dairy, meats, breads, drinks, etc. And so with that, I'm going to use this BLT, no bloody onions, of bones, ligaments, tendons, mnemonic to give you some kind of structure to approach the wrist. So The majority of MSK ultrasound is knowing the anatomy. So I'm going to quickly review the anatomy, and then we're going to dig in to the ultrasound pictures. There's three layers of anatomy. There's gross anatomy, the arm bones connected to the elbow bone, etc. There's the fine anatomy, which is the little lumps and bumps on the bones that you might need to look at. And then there's the ultrafine anatomy. The ultrafine anatomy has to do with what you see on ultrasound. And that's where you get into the millimeter level of resolution that you try to figure out. So with that, before we go too deep, I'm going to start with the basic anatomy. Like I said, there's many bones in the wrist and hand. There's many ligaments, there's tendons, there's nerves, there's arteries, etc. And that goes for all orientations of the wrist. There's no way you're going to memorize that. And the problem when learning ultrasound, from my perspective, when you go to a course, these are all the things you need to look at for a certain region, say the anterior wrist, etc. If you structure it into a deep to superficial approach, bones, ligaments, tendons, nerves, blood vessels and bursa, and then that might give you a little bit of structure and efficiency for scanning. And the whole goal is to be efficient. And I'm a practicing physician and I use ultrasound daily. I've learned some tricks and pearls to do it very quickly. So it gets the job done for what you need. So you're not spending an hour looking at somebody's wrist while you've got 5 patients angrily waiting for you to show up for their visit. So if we go back into the gross anatomy, there are, of course, 2 forearm bones. There's 8 wrist bones, and then you've got all of the metacarpals and the digibones. The key about the wrist is that there are certain key bony landmarks that you want to look for on when you're doing the scanning. On the dorsal wrist, for example, your signpost, your key lighthouse, your landmark is going to be the distal radius, and there's a little bump right here. That's this fine anatomy called Lister's tubercle. And so we will talk about that when we're doing the back of the wrist or the dorsal wrist exam. The other key landmarks that you have are going to be the metacarpals. The metacarpals have this nice straight bone. So when you're looking at the kind of the hand wrist junction, when you want to find those nice long straight bones, because the carpal bones are all curvy wavy and they all look a little different depending on which way you're looking at them. So my suggestion is when you're learning the wrist ultrasound, just track the bones, follow the radius down, and then stay on the thumb side. Look for the scaphoid. It's the first one that's going to pop up. Look for the trapezium, which is going to be at the base of the thumb, and then follow it into the thumb. And then try to follow those carpal bones, again, for each of the digits, radius, proximal row, distal row, and on out. There are certain shapes for some of the carpal bones which are easier to see. For example, the capitate, which is the kind of the centerpiece for the distal row of the wrist, has a kind of a peanut shaped view when you're looking at it. The scaphoid can also look like that, but if you're on the thumb side, you're not going to be looking at the capitate. So you have to know where you are relative to the orientation of the probe. And the tendons themselves are going to be tracking through the wrist, causing a lot of anisotropy, and that's your biggest challenge. Just so you know, the anisotropy tends to be a little bit more pronounced in the deeper structures than in the superficial. So you may or may not see the anisotropy as easily for the very superficial tendons, but if you're looking at the carpal tunnel, the anisotropy in the deeper tendons you will see is more pronounced. Again, it's like looking underwater with a slit lamp and you wave the wand through trying to track it. So with that, let's start with the back of the wrist, or the dorsal side. And what we're going to do is we're going to go through the 6 compartments And I'll also talk about the scapholunate ligament, which is one of those acute injury issues that that you might want to look for. I'm going to try to keep this practical and keep it pertinent to the relative pathology that you might see, rather than just doing a screening of everything, because I'd rather you know at least the more common diagnoses than some of the esoterica. So let's start with the compartments. So there's 6 dorsal compartments. 1, 2, 3, 4, 5, 6. There are 9 nerves in those compartments. Okay, and a way to memorize the number of, not nerves, tendons. There are 9 tendons in the dorsal compartments. The way to remember those tendons and how many are in each is 2, 2, 1, 2, 1, 1. All right, there's 2 tendons in the first compartment, 2 in the second, 1 in the third, 2 in there's 2 groups of tendons in the fourth compartment. We'll talk about the fifth compartment only has 1, and the sixth compartment has 1. 2, 2, 1, 2, 1, 1. And the other mnemonic, which may be helpful for you, the first 5 tendons goes, if you remember, short, long, long, short, long, short, long. And that is the orientation going from the radial side of the wrist across the back of the wrist. So the idea is the names of the tendons may be sometimes challenging. The first compartment is composed of the abductor pollicis longus and extensor pollicis brevis. A saying you can use that sometimes people use is, all peanut lovers eat peanut butter. And that's the first compartment. There's 2 tendons in that. The first compartment is notorious for de Quervain's tenosynovitis, which is going to be a little bit of irritation of the tendons from repetitive use, perhaps a drummer or people that are toggling their thumb quite a bit. And you can use the Finkelstein test, et cetera, clinically to identify that as a presupposition diagnosis, and you can confirm it with the ultrasound. And the first compartment is also associated with the intersection syndrome, which is where the first compartment tendons will glide over the second compartment tendons as they approach the radial wrist. And we'll look at that here in a second with the ultrasound, once I dig into the ultrasound scanning. The second compartment is really the extensor carpi radialis tendons, the 2 of them. There's a long and a short. They don't usually cause much problem, but they can be associated with distal intersection syndrome, which is where the extensor pollicis longus tendon, which is coming from the compartment 3, crosses over the extensor wrist tendons distal to the wrist as it's going over towards the thumb. The people who might get those are typically rowers, weightlifters, things like that. So that would be a clinical supposition. It's not very common, but it's something that you can look for. Compartment 3 is the extensor pollicis longus tendon. That one is very prone to injury because it wraps around Lister's tubercle and can get irritated by that. It can also, with rheumatoid arthritis, can be affected and can easily rupture. Again, you would see that the extensor pollicis longus, so the distal phalanx of the thumb would not be extending, and you would lose the tendons of your snuff box. There's the 2 snuff box tendons are the thumb tendons, the extensor pollicis longus and the extensor pollicis brevis. And just deep to that snuff box is the scaphoid. So as far as surface anatomy, you should be able to see those tendons in a non-swollen or non-puffy hand, and that'll help you define kind of what you're looking at. Compartment 4 are really all the finger extensors, and those are both the extensor indicis proprius is a separate tendon, and then the extensor digitorum tendons. Extensor 5 is extensor digiti minimi that just lifts up your pinky, also sometimes affected with rheumatoid arthritis, something called Vaughan-Jackson syndrome. But with chronic RA, you can sometimes get tearing or disruption of that extensor digiti minimi tendon. And then the compartment 6 is the extensor carpi ulnaris. And that one has also association with rheumatoid arthritis. It can also be irritated by people who are constantly pronating and supinating their wrist, because this tendon can slip off the ulnar styloid. It can slip off the groove and cause some irritation. So let's get into it now and see what just now. That's the kind of the gross anatomy, the fine anatomy. Now we're going to go into the ultra fine anatomy. So if we go into compartment 1 here, and if you look up here, the abductor pollicis longus tendon is going to be sitting right on top. This is in the distal forearm. I'll close this down. You can see it kind of in the proximal wrist. It's above the wrist. It's still over the radius, and you're going to see this little tendon, which is sitting on top of the extensor carpi tendons right below it. And you're going to see this tendon slide over the top. If I run this very slowly across, you'll see it slither down, coming down like that. And so when it gets to the end of the radius, the distal radius, you'll see this little black halo. That's the little tissue that kind of holds the tendon in place. And you're going to see something like this, almost like a loop in a fishing pole, when we do the finger flexors as well. But that little black shadow is the tendon sheath inside of which the tendons will glide, get irritated, and you may see some inflammation. Now, you don't oftentimes see fluid right at the point of this tendon sheath, because the fluid might be proximal or distal, because the sheath is already pretty tight and the sheath can be thickened. But what you want to do is to confirm your diagnosis of de Quervain's tenosynovitis, which is what we're talking about. What you want to do is actually have them move the thumb, watch the tendons glide. And there's a saying that I use in my courses, which is stress Doppler. So you want to stress it or move it, and you want to throw some Doppler on it. Usually power Doppler is all you need. Power Doppler allows you to see the very low flow state. Color Doppler, it shows you the direction of the blood supply. You don't need to know what direction it's going. All you need to know is there increased microvascularity, increased inflammation around that tendon that is causing the problem? Confirms your diagnosis. Is there fluid proximal or distal on the tendon itself? So in the long axis view on the bottom, you can see the tendon coming down this way, and the radius is just deep to it right there. And you'll be able to see that tendon gliding when they move their thumb. All right. So that's the main, for the first compartment, that's the main issue. The other caveat for the first compartment is the abductor pollicis longus tendon can have multiple tendon slips to it. And so you might see multiple black vertical lines in here with inside of this little tendon sheath, because the APL can be segmented. The EPB, the extensor pollicis brevis, usually not, but the APL can. So just be cautionary about seeing vertical black streaks in there. And again, anything that's in ultrasound, anything that's vertical, for example, this little black line here and this little black line there, is oftentimes artifact. I call it fake news. It's because of the physics of sound. And so when you see vertical types of streaks in your image, think artifact first before you start calling it pathology. The other rule of thumb, you always want 2 views of a pathologic condition, not just one. So if you suspect de Quervain's, take it in the short axis, take it in the long axis to confirm your diagnosis, just to support your hypothesis of the diagnosis. Okay, that's compartment number 1. Compartment number 2, we have the 2 the wrist extensors, extensor carpi radialis brevis and longus. Now, remember it goes long, short, long, short, long. So the the idea is that the Lister's tubercle will kind of be your key landmark on the distal radius, and you can feel it on your own wrist. Go ahead and feel that. And the first probe should be your finger, because that gives you a place to start your ultrasound scanning. That little bump is present on almost everybody, and it's a key landmark for the dorsal wrist because it separates the second compartment tendons from the third compartment, which is the extensor pollicis longus right next to it. So, and that also is used when we look at the scapholunate ligament. So find that, know where that sits, because that is going to be your home base. That's your landmark for when you're scanning the wrist. The two extensor carpi radialis tendons, they insert at the base of the metacarpals, and this one goes to the index finger, the brevis, the longest, and the brevis goes to the long finger. So you can see right here, again, longest, brevis, and then Lister's tubercle is going to be sitting right next to it like that. So look for those tendons. Don't usually become symptomatic unless it's the intersection syndrome. So, and if you want to scan it long axis, you can, if you have a clinical suspicion thereof. And what you can do is if you scan the short axis view of the extensor carpi radialis tendons, you should be able to see the distal intersection syndrome. And let me see if I can actually, if this is labeled. Yeah. So right on top here is the extensor pollicis longus tendon. All right, that's the third compartment tendon. That will slither across the two extensor carpi tendons, because you can see right here is the extensor carpi radius brevis and the longus. In this view, the scaphoid is sitting deep right down here. So if you watch this little EPL tendon, it will slither across right here, the top of those tendons, and I'll slide it back and forth. You can see it just kind of sliding across like that. And that kind of constant irritation with rowers and weightlifters, et cetera, people that have repetitive wrist flexion extension may get an irritation at that point, which is distal to the radius. All right, so that's compartment number 2. Compartment number 3, EPL, like we said, is next to Lister's tubercle. You can see it right here, this little circle that's highlighted. Lister's tubercle is sitting right next to it there. And the extensor pollicis longus tendon is the long one that will oftentimes tear versus the extensor pollicis brevis. And it sits right next to the fourth compartment tendons, which are going to be the digit extensors and the extensor indicis proprius. That goes right to the index finger and extends that. But this one is the one that rubs off of Lister's tubercle. It forms part of the snuff box. So take a look at that, and you can see the angle of that tendon. It curves around and then it hooks. So it's prone to abrasion and injury. So that is compartment number 3. If we go to compartment number 4, the compartment number 4 is basically the main finger extensors. Doesn't usually get inflamed unless there's some constant irritation. Sometimes you can have an accessory muscle inside of the fourth compartment, which will slide in and out of all of the retinaculum and the tendon sheaths that are associated with each of these tendons, and that can cause some irritation. Throw some, stress it. In other words, see it, watch it move, and throw some Doppler on it. So stress Doppler. See if there's any microvascularity around those tendons that will support your diagnosis of extensor tendonitis type of thing, or around the tendon sheaths. The fifth compartment is the extensor digiti minimi, and if you look at it right here, this is that little green circle. It sits right over the DRUJ, the distal radial ulnar joint. And you can, and so that tendon will kind of be a landmark for the DRUJ, and it'll sit mostly next to the ulna when it's when it's going through the dorsal wrist. So right here on this view, the ulnar sitting over here, the radius is over here. You can see the fourth compartment, extensor digitorum tendon sitting on the side, but that little tendon, again, doesn't usually get injured, but it can be associated with chronic rheumatoid arthritis. So if that's the clinical situation, you want to look for that, and you look for swelling around the tendon and even actually a full tear. But you'll see if the tendon is missing when they extend their pinky. Yep. Okay, sixth compartment. Sixth compartment is the extensor carpi ulnaris. It sits by itself and in this tiny little groove down here. And you can see this little groove on the ulna. The ulna is the bigger bone right below it, right here. And the extensor carpi ulnaris tendon will sit in here, and it's got a wrapping around that tendon. So that little sheath and that the ligament that holds it down will sometimes get loose, tear, and with repetitive flexion, supination and pronation type of movements, that will cause some instability, say like tennis players, etc. You might get some kind of a repetitive micro trauma stress to that tendon, and you'll see that either partially sublux or fully sublux out of the tendon. It's not uncommon to see a subluxing extensor carpi ulnaris tendon that is asymptomatic. In fact, I would try to look at it yourself. You can sometimes see it dynamically move if you can hold the probe carefully as they move the wrist, but sometimes it's easier just to look at it when they're fully supinated, fully pronated, and see where the tendon lies inside of that groove. Okay, so that's kind of the quick view of the dorsal wrist. I'm going to now go to, that's the tendons. I'm going to go to the scapholunate ligament, because that's where ultrasound can really shine, especially with an acute injury, a fall on an outstretched hand or a fouche injury, because you don't want to get what's called a slack wrist. You don't want to tear the ligaments that are binding the lunate and the scaphoid together. So the way you find that is to actually find Lister's tubercle on the distal radius, and then you slide, short axis slide or transverse slide off of the radius, and as soon as you lose the image of the bone is always your friend with ultrasound. When you lose that bone, look deep, and you will see these two little points. They call it the Thomas tooth sign. There was a famous actor that had a gap in his teeth, and you will see that these two bones just suddenly will appear deep. You may have to move your focal zone. You may have to change your depth to see it. So if I slide this down to, I'm going to move this video, and you're going to see it. You lose the radius right there, and then you look. If you look, there's two little peaks, and then what you're looking for is this hyperfibrillar, microfibrillar little bridge between those two tendons, and you're going to fall right onto it as you go, right there, that little hyperechoic bridge. That is the dorsal scapholunate ligament. There's also an anterior or ventral dorsal scapholunate ligament that you see. So if I highlight this anatomy here, you can see the lunate is sitting over on this side here. The scaphoid is sitting next to it. And then the ligament, the triquetrum, the other bone, is sitting over more towards the ulnar side. Now, there's another ligament over here, which is the lunotriquetral joint, the ligament that also can tear. So those are the two ligaments that you want to look for a fall on an outstretched hand. Those are the two main ones that'll tear. If I go to the advanced labels, you'll see this little bridging ligament fibers, this kind of hyperfine ligament, and then there's a ventral portion of the joint as well. That's going to be harder to see. You can try to change your frequency, lower the frequency, change your depth, see if you can toggle the probe and see the ventral portion as well. But the key thing is this dorsal ligament can sometimes get stretched, and the best way to test it dynamically, if you stress Doppler, you stress it by either having them ulnar or radial deviate the wrist, or you can have them squeeze, make a fist, or squeeze a ball or a gel bottle without squirting the gel all over the place. But you can have them make a fist, and that may just gap that joint, which is a big deal that needs to be surgically repaired, probably because otherwise, if that stays loose, then the whole wrist can decompensate and cause early arthritis in the wrist. There's also many other ligaments that are in the wrist. You've got a lot of ligaments that go up and around, bind the entire wrist, both dorsally and ventrally. Too complicated to go over today, but you can look for things that tears. Not common to tear. The scapholunate ligament is really the most common one. All right, and then the dorsal finger. So if you look at the back, the extensor of the finger, the tendon runs very superficially. My suggestion is to try to follow it in a short axis view, just kind of track it down the finger, but then try to walk on the tightrope and walk along the tendon across all of the joints and see if you can just follow it through to the end of the finger here. So you can see it's very superficial. You might even need like a little bit of a gel standoff pad to see it because it's so superficial. It's just deep to the skin. And you can see this is the, you can see the metacarpal joints here and things. So if I slide this through, you can follow this little green dot. If you can see it, that is all you get for the dorsal tendon, the extensor tendon, and you follow it through the joints until you get past the PIP joint to the DIP joint, and then you'll see the nail bed coming in, and you'll see the distal phalanx right here. If I hone it in on the DIP joint right here, you will see the extensor tendon inserts right at the base of the distal phalanx right here. And this is where you get an avulsion for, say, a Jersey finger or something like that. You can get a little bit of a break off the bone. You'll see the tendon retracting a bit. And you can also see this DIP joint deep to it. What's interesting is also the nail bed. It's very fun to look at somebody's nail when this is the distal phalanx right there. You can see the insertion point. If I put the advanced labels on this, you can see the nail is sitting right over here, and the nail root or the nail bed is sitting just proximal to it. What you see for the nail as it comes out of the skin, you'll see the little cuticle at the end, but this is that's the nail bed. And then that's, again, you look for the DIP joint. So good exercise to just see if you can identify that on your fingers, track that through. All right, let's go to the TFCC. Very commonly asked, show me how to identify TFCC tears. Just like the knee meniscal tears, ultrasound is not the best modality. The problem is that the TFCC actually sits, it sits like a cap at the end of the ulna. So if there's the ulna bone right here coming out, the fingers are this way, distal this way, proximal that. The TFCC is sitting it's coming from the distal radial ulnar joint, the DRUJ. It has a little bit of extension into the joint. It comes up and it forms like a cap at the end of the ulna. Because of the orientation of that TFCC, it's very difficult to define a true tear of it. You may get lucky and see fluid or increased vascularity, especially if you do that stress Doppler. If you move it, you ulnar deviate, and you can maybe see fluid around there if there's an acute injury. But for a chronic degenerative tear, I would not hang my hat on a firm diagnosis of TFCC tear. This is where MRI would be the best bet because it can look deep and it can see inside the DRUJ well, and it can also see the end of this TFCC. you have what's called the meniscoid of the TFCC, which is this other schmutzy stuff that sits outside there. If I put the labels on that, you can see a little bit of the here. That's kind of the meniscoid, and even some of this, the meniscoid should actually goes down into here, but the TFCC is the cap, like I said, at the end of the ulna. Now, if you're looking at the TFCC, you are trying to see if there's an acute injury. Use the extensor carpi ulnaris tendon as kind of a window. It sits right on top, and you can use that as a window to look down into the joint. The other thing is that there's three main bones you should see in the wrist. So if you look at the triquetrum right here, that's the first one, you'll see the lunate that's a little bit deeper. And if you have the right depth, you'll actually see the radius, which is sitting right at the bottom down here. And so if you want to really look at the TFCC, make sure you can see the radius, because the radius extends a little bit further than the ulna. So you should be able to see that stair-step approach. And this is the base of the TFCC, right at that ulnar radius junction is where you're going to see most of the pathology. All right. Now let's go to the ventral, the anterior wrist, the ventral wrist. Okay. That's going to be the carpal tunnels and the Guyon's canal and things like that. So just as a general way to remember this, there's 9 tendons on the dorsal part of the wrist. There's 9 tendons in the carpal tunnel. You've got 8 of the finger flexors, and then you've got the 1 thumb flexor. So you've got the superficial and profundus tendons for the fingers, and you've got the flexor pollicis longus for the thumb. Those are the 9 tendons. The flexor pollicis longus is the most interesting because that sits right next to the median nerve when you're scanning it. So you can sometimes have the patient scan or flex their thumb while you're scanning the nerve in short axis and you're following it down. And I'll show you in this video what it's about. The other thing about the median nerve is as you've probably heard, you can measure the circumference of the median nerve over the pronator quadratus and at the kind of the entrance or in the carpal tunnel itself, and see if there's a size differential, if the nerve appears swollen just proximal to the carpal tunnel. The cross-sectional view of the nerve is much more accurate for confirming carpal tunnel syndrome versus the long axis view of the median nerve. However, ultrasound is an extension of your physical exam. It's an Uber exam. Do not rely on a change in the circumference of the nerve and call a carpal tunnel syndrome diagnosis if they don't have symptoms, if it's not clinically relevant. So be careful about using ultrasound as your only diagnostic tool, because you still have your brain and the history and the physical exam to really have a prior probability of success for diagnosing this correctly. It confirms your diagnosis, and it may assess whether or not the nerve is very, very swollen. You can also see with ultrasound, if somebody does have clinical carpal tunnel symptoms, do they have a ganglion cyst, which is causing the compression, and it's not carpal tunnel syndrome. So it's really an external compression of the nerve from a wrist ganglion. Or and if they're going to surgery, it's helpful for telling the surgeon, do they have a persistent median artery? There's 2 arteries in the anterior wrist. There's the radial and the ulnar artery, and sometimes a median artery. And that persistent artery can potentially cause surgical complications if the surgeon's not aware of it. The other potential surgical complication is the recurrent motor branch to the thenar muscle, which branches off at the distal end of the carpal tunnel. And that will be a little branch that separates from the median nerve, and it goes towards the thenar muscles. 98% of the time, it goes on the thumb side, the radial side of the bifurcation. But 2% of the time, it'll go ulnar, and then it crosses over to the thenar muscle. If it's going to the ulnar side and the surgeon is kind of approaching it from the ulnar side, it's good to let them know that they may have an ulnar deviating thenar motor branch that could potentially cause a nerve transection if they're not careful, which then loses the function of their thumb. It's called the $5 million nerve. Not great. So if depending on your relationship with your referring sources, I oftentimes will screen for is it a radial or ulnar deviating motor branch of the nerve. So let's track the median nerve with this. So right here is the median nerve sitting in the distal wrist or the distal forearm. That's oftentimes the easiest way to locate it initially. It floats in the middle of the muscle bellies. It has that kind of raspberry golf ball looking ovary appearance and the honeycomb, and you can just track it down the wrist, and you will see that this nerve will the muscles will turn into tendons, and then this nerve will kind of swing up into the entrance of the carpal tunnel. So here you can see, if you follow the purple dot, you can see it right here. And right over here those are the fibers of the pronator quadratus. You want to look for those striated muscles. And that's where you do your measurement for the circumference of the median nerve there. And then if you follow it up, you can see it's sliding up and it's sliding up. So here it turns into a little bit darker. And this nerve will go from hyperechoic to hypoechoic as it goes into the carpal tunnel. So sometimes challenging to see, but again, right next to it, you will see the flexor pollicis longus tendon. And if you watch this little tendon right next to the median nerve, during the scan, I recorded the flexion of that right there. Can you see that tendon just moving? That's the flexor pollicis longus tendon. And that just kind of confirms which is the flexor pollicis longus. You can see abundant anisotropy of the deeper tendons. Like we talked about, anisotropy is a little bit more present as you go deeper. And so you can see the superficialis and profundus flexor tendons are dark in this view. The median nerve oftentimes has a little bit of a hyperechoic bright ring around it from the perineurium. And then you can slide in and you look for this rainbow arch that's coming across right here. And that is the entrance of the carpal tunnel. And as you follow the nerve down, you can see that it will flatten out. It flattens out as you go through the carpal tunnel. And then at the end, I will show you the distal carpal tunnel. This is the median nerve right here, that little purple stripe. Now, if you look at this little extension, you will see the recurrent thenar motor branch branching off the median nerve. So you look for that little black extension that goes towards the thenar muscles. If it's going that way, you may be, the surgeon could be in trouble if they're approaching it kind of from the ulnar side of the nerve, which is how they usually will release the carpal tunnel. Some of the key landmarks include the hamate, the hook of the hamate, and the other wrist bones. But the key thing is really just trying to track that median nerve down in long axis. It is nice to see the median nerve because it has a little bit of a soda straw type of appearance. It's got a little hyperechoic rim, and then the tendons deep to it tend to be a little bit more fibrillar. And again, you can wiggle the fingers, have the patient bend their fingers, and you'll see a little bit of movement of the nerve, but a lot more movement of the finger tendons. That's the stress Doppler concept. So with that, you can try to track the nerve down as best you can. Let me just see if I can light this. So it'll dive down into the carpal tunnel. The transverse carpal ligament is sitting right on top. That little triangle up on like a little lens-shaped covering on top of the nerve. And sometimes it's helpful to see if there is a little notch in the nerve, because even after a carpal tunnel release, they may still have symptoms. And I've seen cases where there's still preserved transverse carpal ligament tissue that is squeezing the nerve, and they didn't get relief of their symptoms. The surgeon said, they waited too long, but the problem was that they didn't complete the job. So you can look in the long axis for the median nerve and see if you can identify a little bit of a narrowing going that way. So that's the carpal tunnel. The ulnar nerve, as you know, goes through Guyon's canal. Guyon's canal is outside of that transverse carpal ligament. It tends to not get compressed unless you have somebody that's got a tendency to put pressure on the palm, like biker's palsy, because the ulnar nerve will branch and it goes right over the hook of the hamate, and we'll show that with the scan. That firm pressure over the hamate will put pressure on the motor branch of the ulnar nerve. There's three parts of the ulnar nerve at the wrist. You've got the proximal, which contains both the sensory and motor, and then it'll branch into the sensory nerves that go to the small finger and half of the ring finger. And then you got the motor branch, which, like I said, hooks over the hamate and causes some compression. So if we look at that very quickly, you can see that the inside of Guyon's canal, you have to basically follow just follow the nerve in short axis as best you can through the tunnel. Look for that little honeycombed nerve and follow it through the system as best you can, understanding that you're going to go into this Guyon's canal region. You'll see this little pisiform bone that pops up, this little valley, and that this is actually part of the carpal tunnel right here, but the Guyon's canal is sitting right up here outside of the carpal ligament, right up here, and that's going to be your key landmark for seeing if there's usually a ganglion cyst. It's not usually going to be squeezed inside a Guyon's canal itself. It's usually going to be an external compression from a ganglion that's branching off one of the wrist joints. And the pisiform is sitting over there. Ulnar artery should be sitting right next to it, right there. If you scan down, let's go back to Guyon's canal, you follow that little purple dot, you will see a little, as we go down the hand, distal on the hand, you will see a little bit of a bright white little reflection. That's all you see of the hook of the hamate. You have to be looking for it. You have to know what you're looking for and know what you're looking at. But you can see that the ulnar branch right here sits right over the hook of the hamate, and that's where you want to see if there's some swelling, and compression, and you can push on it clinically and see if that reproduces some of the symptoms. The sensory branch is branching off towards, like I said, the small finger. So, and again, I'm ripping through this because of the time constraint, but I hope this is helpful for you. Flexor carpi radialis and the flexor carpi ulnaris tendons do not go through the carpal tunnel. Those are the two tendons that will go outside the carpal tunnel, more superficial. So look for that little rainbow arch of the ligament. And the third tendon, which may be outside of the carpal tunnel, is the palmaris longus. Not everybody has a palmaris longus. Some people only have it in one hand, etc. But it's going to be that if you pinch your thumb and small finger together, you'll see that little bulging tendon. That's the palmaris longus tendon. Not always present, but so there's two tendons that go outside of the carpal tunnel, and sometimes three, which is the palmaris longus. There's two arteries that are in the anterior wrist, the median and the ulnar arteries, and sometimes the persistent median artery. So the radial artery, ulnar artery, and sometimes the median artery. So you want to make sure that there's no median artery at around the median nerve if somebody's going for carpal tunnel syndrome. All right, and then the finger flexors. So the finger flexors are somewhat fun because you can track them down the finger just like we did with extensors, but you track them all the way lengthwise down and follow them through the joints and the bones of the fingers when they insert on the distal phalanx. In the short axis, though, the key thing, the pathologic issues is going to be the A1 or the A2 pulleys. And those are basically, like I said, like little loops of a fishing pole that hold the tendon down. And when the tendon is sliding back and forth through there, especially if that little loop gets thickened, it can cause the stenosing tenosynovitis, the trigger finger type of thing. That's for the A1 pulley. And the A2 pulley is in the middle of the proximal phalanx. And that is basically going to hold that tendon down along the bone. That can rupture if you're a climber, if you suddenly grab something like a heavy toolbox or something and it hits your fingers, it can pop the ligament, and we'll show that here in a second. The key finding for the pulleys is that you're going to have that black little halo around the tendons. So if you look at the cross section of the tendons here, and this is sitting right at the the distal palm right here, you will see that the superficialis on top, the profundus is the tendon below, and the third layer of the hamburger is the volar plate. The volar plate is basically like a little tissue that's attached to the end of the more distal bone, depending on what you're looking at, and it's like a little tail, little triangular tail, and I think of it as keeping the tendon from squeezing into the joint. Here you can see the bone down deep to it, so it has this kind of hamburger appearance. If you look at it in the cross-sectional view, you can see here's the metacarpal right here. This is the proximal phalanx, and you can see the profundus here, the superficialis here. If I put the advanced labels on, you'll see this volar plate that sits just deep to the tendons. That's a little tail that attaches to the base of the phalanx. And when you move your finger, you'll see that volar plate move with the finger. So that is the third thing. And then you've got the joint down deep. If we follow this this tendon through, well, actually, if we do the short axis and we follow the short axis through, see if you can identify where you start to see these little black halos coming through. And so you will see right here, you can see, again, there's a little black halo around the tendons, and that's going to be another pulley. And then there's nothing. And then you'll see another little bit of halo around the tendons. See if you can identify those little loops of the fishing pole. In the long axis, it's a little bit more, I think it's more fun. You can see right here, here's the A1 pulley sitting right on top of the tendons, this little orange view. And if I slide down the finger, you can see right here, there's a little lens-shaped black slither that is the A2 pulley that is holding that tendon down against the finger. Let me see if I can get that to line up here. Yeah. Well, I don't have it. I don't have that one labeled, but you can see it right here. Right here, you can see the A2 pulley, and then you can see yep. Let me just cue it up here. And you'll see the finger flexors, the superficial and the deep. Okay, so as I slide down the finger, you'll see the tendon glide up over the PIP joint, the proximal interphalangeal, the phalangeal joint. You'll see the middle phalanx, and you'll see kind of this A4 pulley sitting just deep to it right down here. And then you go to the DIP joint, and then it'll insert into the base of the distal phalanx down here. The distal phalanx is, in this case, sitting right here. You can see the flexor digitorum profundus attaching to the distal phalanx right there. So that is kind of a whirlwind tour of the wrist. I went over my 45-minute slot, but I'll open it up for questions just to kind of.
It's okay. It was a wonderful presentation, Dr. Gronseth. Thank you so much. And Dr. Gronseth has prepared a few quiz questions for you. So I'm going to launch those now. There's 4 questions. And then I'm also going to launch a learning score question following it. So get those quiz answers answered, and then we'll launch the answers and then the learning score question. As we wait for the answers to roll in, Dr. Gronseth, we did get a few questions in the comments section that I wanted to read to you. Maybe we can answer those now. Is that okay?
Sure.
Okay. So one of the first questions was, is there a program fee or is there a subscription or registration fee associated with this program?
with the software, with the MSK Nav.
Correct.
Oh,
Yes. Yes.
yeah,
With your presentation, you're
yeah. So again, I use this just for efficiency of today's lecture. Yes, there is. If you go, I started a software company, as you can see, 7dimaging.com. It's actually 7d-imaging.com, which is the official website. There you can see the subscription options for the MSK Nav. And I made
awesome.
this kind to be like a Google Maps of the body for ultrasound images. It has a lot more information than what I showed you, but there's different types of subscriptions. It is sponsored for 66 credit hours of CME for those that need that as well. So I would just suggest you go to the 7dimaging.com and you can take a look at it. Mhm.
All right, thank you.
Thanks for your
And then
interest.
another question, and I did put the link to 70 Imaging in the chat for anyone that wanted to look further into the program and the software. Another question about the software, Dr. Gonsev, is MSK Nav available for Android?
It Not yet. We are working on it right now. It only works on iPads, but it works on iPad 2s, which you can probably get for $25 on eBay. It is a software that was designed to download to the iPad itself so that it works offline, because sometimes the internet access is not that great. It was designed to work in low resource areas. Like Tiffany said, I started a nonprofit that teaches basic ultrasound skills to midwives. We have a similar version for prenatal scanning. And so the whole goal for the software was to work offline. All the information downloads to the iPad. So it works offline. It works just as fast. Once you have it, it works and as fast as the Amazon jungle as it does in Silicon Valley. And but we are trying to convert it to a phone-based system. Right now, it's iPad only. But if you can get your hands on an old iPad, it'll work. It's still functional.
All right, awesome. And I
And
know we're getting a few.
it can also work on Apple MacBooks with an M1 or M2 processor, because that accommodates kind of the iPad iOS system into that processor. But regular PCs, Android, it's not yet functional.
Thank you. And I know we have a few questions in the chat regarding if this presentation was recorded. And yes, it was. And you will receive the recording in your email inboxes and within a week of this presentation. And now we're going to get started with the Q&A portion of the webinar. So the first question, Dr. Gonsev, they first are thanking you for the presentation. And when doing ultrasounds of the joint, how do you stabilize the probe to make finger movements and still get the images? Because most of the time when I try that, the probe keeps going in and out of view.
Yeah. So a couple of things. If I go back to the software a little bit, there is a setting that says patient position, and that I didn't go through. But so the technique of doing the scan is challenging for the wrist and hand, simply because the parts are so small. Sometimes it helps to use. First of all, you have to use a lot of gel, and sometimes you can kind of keep the gel between your probe and the skin by using your fingers to keep it contained, because it can get very, very messy. Sometimes having a towel roll under the wrist, depending on what you're looking at, or even a towel roll or a gel bottle in their hand that they can hold on to, allows you to look at things. The key is to sometimes use two hands. So you can either use two hands to hold the probe, or if you just stabilize, you always have, I always say that ultrasound is a contact sport. So you want to have your hand on the patient's body, and then you put the probe down so that you can actually, I was just looking for a probe here. Here's a little sample probe I have. So you can use that and keep your hand on the body. And then when you have the view in place, then you can have them very gently just scan. Now, the key thing about the wrist and hand is that, like I said, everything is small. So you have to use very small movements. And the other thing you have to do is you have to learn how to rotate the probe, pivot the probe so that you can kind of keep it in line. Whenever you're looking for linear structures like nerves, tendons, always go in the short axis view or the transverse view and then scan down. When you try to go long axis view on something that's linear, like a nerve or a tendon, it can be very challenging. You have to, you go, and if you lose it, you can sweep back and forth, see if you can find that line again, and then go down a little bit and go back and forth. And so it's just going to take practice. I would suggest you do it on yourselves first. You all have, the tendons and fingers and toes that you can practice on, or use your family, and just get comfortable with the idea that it's going to be very, very subtle movements, and you have to learn how to turn the probe from a short axis to long axis. Sometimes I will get the tendon centered, and then I'll just look at my probe and literally just rotate 90 on the center of the probe, and I usually fall onto the long axis of the area of interest. So if I'm looking at a tendon, I might go short axis. I get it centered in my view, right down the middle of the screen, and then I'll just literally just rotate it, and then I'll scan back and forth and try to find that long axis tendon. I hope that's helpful for you.
Thank you. The next question, will you be able to see or how to see possible chondrocalcinosis in the TFCC as part of the CPPD disease?
So yeah, so you're talking about gout and pseudo gout, and so CPPD, which is a calcium pyrophosphate disease, those crystals will settle inside of the cartilage. So you'll see it embedded, especially if you're looking at a knee or something with abundant cartilage. You'll see little specks inside of that cartilage. Gout, which precipitates out of the joint fluid, will settle on top of the cartilage, and it forms this little bright line, this parallel line called the double contour sign for gout. The CPPD, you can look for crystals inside of the TFCC. However, the TFCC, like I said, is notoriously poor at scanning because it's oriented in the wrong way. If you could get the probe into the joint and look at it this way, it would be fine. But because you're looking at it in long axis, it's very difficult to make a firm confirmatory diagnosis. You're better off with an X-ray and then you zoom in on the X-ray at the TFCC junction and see if you can see small little bright dots inside of the TFCC where you should see a normal empty joint space. And that's going to be a more definitive, sensitive diagnostic tool than ultrasound. Just my bias. I don't have great confidence with diagnosing TFCC disease with ultrasound. I try, but I really can't confirm a diagnosis with it.
Thank you. The next question, have you used an ultra high frequency transducer, 20 plus megahertz, on the wrist, hand, and did you find it useful?
Yes, the higher the frequency, of course, the better the resolution, right? I think if a low frequency probe is taking cuts through a plane like this, a very high frequency is taking multiple cuts. So you're going to see a lot more detail. But as the very high frequency probe takes multiple cuts, it's going to lose its power. So obviously you're not going to get deep into the joint. The higher the frequency, certainly the more detail you're going to get. From a practical perspective, I'm not sure it has huge value because even an 18 megahertz probe or even a 12 megahertz, you probably can see what you're going to see based on the clinical situation. Now, again, I advocate that the ultrasound is an extension of your physical exam. So if you need to, confirm something, a small little deposit somewhere, a micro tear or something, that's possibly fine. I think from a clinical perspective, it can be useful. Do I use it? No. Have I seen it? Yes. It does not penetrate. I think for the wrist, if you've got the superficial tendons, you might be able to look at it. Certainly for the fingers, which are very superficial, may be good. Again, the value for the use cases for me, just based on speed and my practice. I'm a physiatrist, so we do a lot of the big things. Not a rheumatologist. I don't have one, but they're fun. Yeah.
All right, thank you. And our last question, when to consider the thickening of A1 pulley, specific measurement? So two questions, like when to consider thickening A1 pulley, question mark, and is there a specific measurement, question mark?
Well, I'll go back to my original statement. Ultrasound is an extension of your physical exam. So if you've got the trigger finger or stenosing tenovitis or pain with a finger flexion, you already have 90% of your diagnosis. Do you have to measure it? It might, it may be thick, it may be thin. If they've got it, and I would show you my scan. I actually have a thickening superficialis tendon, and you can see the A1 pulley kind of bow up as my tendon is sliding through. Perhaps another time I can do a live demonstration. But in my opinion, does it really matter what the diameter is, because it's an extension of your physical exam, the clinical situation. You can measure it if you wish. I don't know if it adds any value. Time is precious. I don't. You can certainly, tell a patient, yeah, look how thick it is. You can tell the surgeon, look how thick it is. But if they have to slice it, doesn't matter how thick it is. They're gonna just treat it. So it depends on whether you want to go into the academic, the minutia of that's interesting. Just like all of the anatomy of your wrist and hand, there's a lot more I didn't cover. All of this tiny little nerves and arteries and things, and you can look for those. Does it clinically matter? I'm not sure. I'm just kind of giving you kind of a practical approach to the wrist and hand. This is a 6-minute, the 6-minute scan of the wrist. Obviously, I went longer than 6 minutes, but you can see that if you've got the time and you want to measure something, it's always sometimes when you don't know when you're looking at or what you're necessarily what's going on, it's always good to just measure something. But take a picture and measure it just to say you did something. I don't know if it doesn't match the clinical situation. However, I'm not sure it has a huge value.
Thank you. Well, Dr. Cliff, that concludes our Q&A session for the webinar. Thank you so much for being our presenter. And to the audience, a recording of this webinar will be made available on the POCUS.org website in approximately 1 week, and you will receive a link via email. Thank you for attending our webinar today, and we look forward to seeing you on a future webinar. Take care.
Thanks a lot, Tiffany. Have a good day.
Thank you, Dr. Cliff.
You're very welcome. Have a good one,
Take
everybody.
care.